Hello and welcome to the Independent Hospital Pricing Authority webinar on contributing to the future of hospital pricing policy, engaging with IHPA on the Pricing Framework 2022-23 consultation. I'm Sharita Daylat, Director of Policy Development at the Independent Hospital Pricing Authority.
And I'm Samuel Webster, the Director of Pricing.
The purpose of this webinar is to highlight the key issues in this year's consultation paper and to engage with and encourage submissions from stakeholders to provide an avenue for interested parties to ask direct questions of IHPA senior executives and technical advisors on the contents of the consultation paper and the submission process. We will be hosting a live Q&A session on Tuesday, the 22nd of June, where interested stakeholders can participate by asking senior executives relevant questions. The purpose of the Pricing Framework for Australian Public Hospital Services, which we will refer to as the Pricing Framework, is released annually. The Pricing Framework underpins the National Efficient Price and National Efficient Cost determinations for each financial year. The Pricing Framework consultation process is an opportunity for stakeholders in the health sector to provide input towards improving the sustainability and effectiveness of the Australian health system. It provides an additional layer of transparency and accountability by making available the key principles, scope and approach adopted by IHPA to inform the NEP and NEC determinations. It covers IHPA's core work areas, including scope of public hospital services, the classifications used to describe their pricing mechanisms, data collection and safety and quality. This year, IHPA released the consultation paper for public consultation on Wednesday, the 9th of June, with submissions due Friday, the 9th of July, 2021. The pricing framework outlines IHPA's key priorities for any given financial year. Sam and I will now step through the key changes outlined in this year's consultation paper. Firstly, there are changes arising from the release of the federal budget. So the budget was released on the 11th of May 2021 and contains two significant measures that impact IHPA's current role. That is the expansion of IHPA to inform Australian government decisions on annual funding increases in residential aged care from 1 July 2023. IHPA will also have a role in home aged care pricing advice from 1 July 2023. And secondly, working with the Department of Health and key stakeholders to support reform to the prosthesis list, specifically to reduce the cost of medical devices used in the private health sector and to streamline access to new medical devices. We're not seeking feedback on these in the consultation paper, and they're just noted for stakeholders. Secondly, we received extensive feedback from the pricing framework last year, so 21-22, regarding the impact of COVID on models of care and service delivery. This year's consultation paper will include analysis and seek feedback on IHPA's proposed approach for using the 1920 cost and activity data to assess the short-term activity and potential pricing impacts of COVID on National Efficient Price Determination 22-23, which we will refer to as NEP 22, and seek stakeholder feedback on any recommendations on how IHPA should account for the impacts of COVID in the coming years. Specifically, IHPA has conducted analysis of activity and national hospital cost data collection data to investigate variations in activity and costs compared to historical trends. So this includes changes in acuity and case mix, changes in length of stay and cost per stay, the impact of reduced ward capacity, changes in funding sources, and activity and costs associated with codes and N classes, which were implemented to record COVID-specific activity. Moving through to the classification section, this year IHPA is seeking feedback on an approach to standard development cycles for all classifications. So IHPA's admitted acute classification systems undergo refinements through established 3-year development cycles. And IHPA is seeking feedback on the feasibility of implementing a standard classification development cycle for the other patient service categories. So the consultation paper seeks feedback on the preferred timeframe and for the development cycles and measures that should be standard as part of the review and development of updated versions of the established classifications. The admitted acute care IHPA uses, in the admitted acute care space, IHPA uses the International Statistical Classification of Diseases and Related Health Problems, 10th revision, Australian modification, ICD 10AM, the Australian Classification of Health Interventions, ACHI, and the Australian Coding Standards, the ACS, 12th edition, and the Australian Refined Diagnosis Related Groups Classification, ARDIGs, to classify admitted acute patients. For NEP 22, IHPA will price admitted acute services using ICD 10AM, ACHI, ACS 12th edition, and ARD version 10. The consultation paper will provide an update on the development of the online educational materials for this classification and at the phasing out and support of older versions of the ARDIG classification.
All right, moving on to admitted subacute pricing. So the public consultation period for the draft Australian National Subacute and Non-Acute Patient Classification System version 5 closed on the 10th of May 2021. So there are a number of proposed refinements in that draft classification. The consultation paper summarises these refinements and outlines IHPA's intent to price admitted subacute and non-acute care using AM SNAP version 5 for NEP 22. We're also seeking any feedback on any barriers or additional considerations to using AM SNAP version 5 to price admitted subacute and non-acute services in NEP 22. Moving on to mental health care. So IHPA published indicative price weights for the Australian Mental Health Care Classification version 1 with the NEP 20, so in March 2020. That was for mental health activity in the admitted setting. The AMHCC also provides, is also a classification used to collect community mental health data. And for NEP 21, so in March this year, we published indicative price weights, or shadow price weights we call them, for both admitted and community mental health care. For NEP 22, IHPA intends to price admitted mental health care using the AMHCC following this 2-year shadow period. So this is required under a recent addendum to the National Health Reform Agreement, which we'll just refer to as the addendum. Once a thorough assessment of the quality and coverage of this mental health care data has been undertaken, those will assess the potential to price using AMHCC for the admitted setting and continue shadow pricing in the community setting. So progression to pricing admitted mental health care using AMHCC can potentially impact a number of block-funded services, specifically standalone specialist psychiatric hospitals, which predominantly deliver admitted mental health services, or predominantly deliver mental health services. And the consultation paper is seeking feedback, firstly on the feasibility of transitioning these hospitals to an activity-based funding, and also seeking feedback around the readiness to progress to pricing with AMHCC for admitted and community healthcare for NEP 22. Moving on to more general pricing consultation questions. So each year we consider adjustments to the national pricing model. So the pricing models are built to ensure that the Commonwealth is paying the same price for the same service all over Australia, whether you're in the RPA in Sydney or at the Alfred in Melbourne. And we also recognise that there are some unavoidable variations in cost, for example, due to remoteness. And each year we assess a number of different adjustments for their inclusion in the national pricing models and consult on potential other adjustments which we should be implementing. So this year we'll be working to further understand any of these unavoidable drivers of cost. We're specifically focusing on further understanding the impacts of, or the cost drivers associated with patient transport in rural areas, for example, aeromedical evacuations. We'll be reviewing the eligibility criteria for specified intensive care units and how that adjustment is applied in the model. We'll be reviewing the Indigenous adjustment and adjustments and considering adjustments related to genetic services and socioeconomic status. So the consultation paper is seeking feedback on what factors should be considered in reviewing these adjustments specifically, but also what evidence could be provided to support any other additional adjustments that could be considered this year. The next key area in pricing is around what we call unqualified newborns. So IHPA has received feedback from a number of stakeholders detailing concerns around how unqualified newborns are currently accounted for in the national pricing model. So newborn qualification status is assigned to each patient day in the admitted setting with a newborn episode of care or newborn patient day is qualified if the infant meets at least one of a particular set of criteria which are outlined within the consultation paper. And newborn patient day is considered unqualified if the infant does not meet any of those criteria. So unqualified newborns are currently not considered in scope for admitted patient data collections for activity-based funding, although their costs are assigned to the mother's record and are included in the delivery ARDRG price. So this qualification status means that hospitals do not receive separate funding for unqualified newborns receiving medical treatment while on ward with their mother, which may result in unqualified newborns which require specialist medical care and nursing attention being separated from their mothers for funding purposes. There's no incentive for providers to keep them together currently. For NEP 22, IHPA is investigating the current funding model and how around unqualified newborns, and if the methodology does require any changes or refinements in this area. So we're seeking feedback on what factors IHPA should be considering when investigating these methodology changes, specifically around unqualified newborns. The next key point for consideration is around price harmonisation. So IHPA's pricing guidelines published each year include certain system design guidelines which inform the design of our ABF and block funding models. And one of these, or some of these key guidelines include objective for price harmonisation, which essentially says that the same service should be given the same price regardless of, for example, administrative decisions around whether to admit a patient or not. So if the same service is being delivered in two different settings, if it's literally the same service, then they should get the same price. We call this price harmonisation. We currently harmonise the price for interventional imaging and for endoscopies, and we are continually assessing where we can potentially harmonise prices for other services. We're currently looking at hemodialysis across the admitted and non-admitted setting, and also for chemotherapy services. So we undertake clinical consultation to inform this piece of work, and the consultation paper is inviting feedback on any other clinical areas where we could introduce price harmonisation within IHPA's pricing models.
As mentioned by Sam, the addendum to the National Health Reform Agreement was released in May 2020, and under the addendum, IHPA is required to support work in investigating and trialling innovative models of care that focus on outcomes that matter to patients. So IHPA has developed a draft future funding models for Australian public hospitals discussion paper, which outlines IHPA's approach to address the addendum requirements around trialling funding arrangements for innovative models of care. The consultation paper will include an overview of IHPA's preliminary analysis in investigating potential patient cohorts amenable to bundling or capitation payments, which are the two approaches that IHPA is currently considering. It will identify critical success factors and notes that IHPA is seeking expressions of interest from jurisdictions to trial innovative models of care for NEP 22. The consultation paper will seek feedback on considerations that IHPA should consider in investigating innovative models of care and explore trials of new and innovative funding approaches. A follow-on from that is pricing for and funding for safety and quality. Again, under the addendum, IHPA is required to provide advice on evaluating the existing safety and quality reforms. That's specifically the sentinel events, hospital-acquired complications, and avoidable hospital readmissions to support the consideration of any new safety and quality reforms. Additionally, IHPA is required to work with the other national bodies, so specifically the National Health Funding Body and the Commission of Safety and Quality in Healthcare, to investigate options for reducing avoidable and preventable hospitalisations. This work is closely tied with supporting innovative models of care as a development of alternate funding models to incentivise provision of care away from the admitted activity towards community-focused preventative care is a key element of minimising unnecessary hospitalisations. The consultation paper will provide an update on IHPA's work to address the requirements and the addendum around the evaluation and investigation of further safety and quality reforms. It will specifically seek feedback on what pricing and funding approaches should be explored by IHPA for reducing avoidable and preventable hospitalisations, and specific assessment criteria and what IHPA should consider in evaluating the merit of different pricing and funding approaches for reducing avoidable and preventable hospitalisations. So the next section we're going to move through to is to provide stakeholders an opportunity of, we're going to give a bit of advice on making a submission, how to be heard by IHPA, and tips on producing an effective submission to inform IHPA's pricing process.
Alrighty, so I've got a couple of key points here that you should consider when making a submission. So first and foremost is to recognise IHPA's role within the system. So what are IHPA's prescribed requirements, and what is the remit of IHPA in terms of ABF and block funding in the context of pricing hospital services in Australia. A lot of this is detailed in our corporate plan, work program, NEP and EC determinations that are all on our website. And I strongly encourage anyone making a submission to familiarise themselves with exactly what IHPA's remit is and what kind of advice and suggestions we can implement into our work. It's also focusing on our core work areas. So the majority of our resource and time is spent on developing the NEP and NEC determinations, new and existing classifications, safety and quality, and the new requirements introduced under the recent addendum. So definitely focusing on IHPA's core work is really key. Next is to understand pricing, so familiarising yourself with how hospital pricing works, so that your submissions or suggestions or proposed methodological improvements can be implemented, within the policy framework within which IHPA is operating. Clearly outline your goal. So what areas of pricing or funding does your goal relate to? So I guess going through previous pricing frameworks or going through last year's pricing framework to understand exactly what decisions were made from there, reading the NEP and NEC determinations, and really outlining as part of your submission what the intended action is or expectation is that we could evaluate as part of that process. Make your expertise clear. So tell us about yourself. What's your area of expertise? Include your contact details, how to contact you, get back to you to clarify or respond to your submission. Outline your priorities. So the pricing framework outlines IHPA's priorities in a given financial year, and it is important that your submission and your goals are linked to IHPA's priorities in some way. So that will really enable us to work it into our work program or to assess it in the context of our work program for consideration in the next pricing framework. A fairly key one, so is just you only have to focus on your area of interest. We'll often get submissions to or responses to the consultation paper on the pricing framework, in which an expert in a particular area will try and answer every single question in the entire consultation paper. So it's not a requirement to respond to each and every section. The most effective submissions will focus on a particular area that a stakeholder has expertise in and can best contribute to. And the next one, and I think coming from a pricing background, is one of the most important for me, and that's provide evidence. So with any submission that you're making that includes recommendations for particularly around methodological updates or suggestions for adjustments and harmonisation, it's most effective if that includes a solid base of evidence, so including references or other forms of evidence to support the context, refer to relevant studies, whether they're from Australia or from overseas, and the best evidence is often to have data-driven evidence. So all of the decisions that we make at IHPA, the prices that we set, adjustments we make are all data-driven. And so one of the things we always do is to look at the data we have and see if the Australian hospital activity and cost data supports the recommendations or suggestions that might be made as part of the submission.
Thanks, Sam. So as mentioned at the beginning of the webinar, IHPA released the consultation paper for public consultation on Wednesday, the 9th of June, 2021, with submissions due on Friday, the 9th of July. Just to finish up, just a reminder that we will be hosting a live Q&A session on Tuesday, the 22nd of June at 12 p.m. Australian Eastern Standard Time. And this is a great opportunity to provide stakeholders, with an opportunity to ask our senior executives any specific or particular questions. So we encourage you to come along and be involved in that session.
All right, thanks.
Thank you.